I'm going to kind of give a primer and kind of give you a background to why we thought this was necessary to go about developing this tool that Michelle will share more information about, kind of talking a little bit about the requests that we get at the State Health Department, and some of the things that I see as I've worked with different community groups and that sort of thing over this last several years. A little bit of background on myself. I am the CDC Epidemiology Advisor stationed at the Indiana State Department of Health. I've been there for about 3.5, almost going on 4 years. I've worked in various areas within that, from infectious disease to injury prevention to cancer. So I've had a pretty diverse background as far as working at the State Health Department. So which has been nice because I got to know a lot of the data sets and a lot of the available data that's out there for Indiana at the state level and more at the local level as well, or sometimes the lack of data. And we'll be discussing that more as we go along. So our topic today is getting the data you need, and I'm just going to kind of start moving forwards. If anyone has any questions, just feel free to ask. So I took this picture out front of the building. Hopefully the people on camera can see this. So they're doing some construction here. Of course, the foundation might be a little bit troublesome here, so I don't know if you can tell the picture. So my main take, and I'm sorry that I guess this version of the computer threw it off, what is our foundation built on within epidemiology, within public health, and usually that's data, usually with the A down here. So how do we get about getting the good data that make sure we have a strong foundation? So usually I use the 4-letter word data, and heads start to nod. I think you guys came here at 8 o'clock in the morning, so you probably are data junkies and nerds like I am, so it doesn't really bother you. But hopefully as we go along, it'll be somewhat interactive, so we'll prevent against that. So at the State Health Department, what are some of the reasons why we get requests for data, of course? Educational, we got a lot of people that are studying for MPH, doing other studies as far as their educational background, so they ask for data that helps support that, whether as an intern at our place or externally and just needing the data. One of the big things, development and implementation and evaluation of interventions, whether that's at the community level by a nonprofit organization or some other community group that's kind of risen up to do something in their specific community. Development, implementation, and evaluation of policies and systems change, which is another growing area right now. Just general research is another area that we usually field a lot of questions for. And then this one's kind of cross-cutting across a lot of these is community assessment. And that's one of the biggest growing areas right now. For communities doing community assessments, maybe to get grant funding or whatnot, but also for groups like hospitals who now every 3 years have to do their own community assessment if they're a non-for-profit hospital. So we're trying to figure out how does the State Health Department work in that? How do we get resources, data resources available for those groups so that it helps meet their needs as well? So at the State Health Department and the state of Indiana in general, we're usually pretty good about describing this, the state of Indiana, right? We have lots of data that helps describe what's going on across the whole width and breadth of Indiana. And then we get to the county level. It's kind of hit and miss a little bit. We have some good data resources, some we don't. Maybe we can't always explain what's going on, especially if we want to do it in a timely fashion. And then if we get smaller, zip code level, census tract level, a specific neighborhood, then it's pretty sparse. We really can't do that. And talking with multiple groups, this is what I get feedback about, is, hey, where do we get data for this? And sometimes we have to say there is no data. Sometimes we say there's data, but with these limitations. And then sometimes there is other data. And that was kind of the impetus for this group. What we've been doing is developing this tool that Michelle, again, will be describing more in detail later about, hey, there's lots of gaps here. But here's a collection of them that we know are good, that have been vetted, that you can use at the local level possibly. So the first thing a community always needs to do, a lot of these people are not experts. They haven't had any epi training. Again, data to them is the 4-letter word. That's a bad 4-letter word. And they really don't know where to start. The other nice thing about the tool that Michelle will be going into a little bit more is it kind of says, okay, you're at step A, okay? So we're playing the chutes and ladders game, okay? So a community is going to hit a lot of ladders if they don't know what's going on. This tool is meant to help guide them through it so they don't hit as many chutes, and get more ladders as possible. So what it does, it walks through a lot of this terminology. So one of the big things is quantitative versus qualitative data. And I know a lot of you know what these mean, so I'm going to kind of breeze through that. But in general, so quantitative data, we're usually pretty good at that. So it's the what? It's the amounts, the quantities, the rates, that sort of thing. What sometimes we're not as good about is qualitative data, because one, we just don't have the training about how to collect it, and then even so more after that is how do we interpret it, and then how do we link it back into the quantitative data to make this such more rich of a data source. Okay? So it kind of walks you through that. So one of the biggest ones, and one of the ones I get the most questions about, is the Behavioral Risk Factor Surveillance System, or the BRFS, or the BRFSS, or the Big B, or however you want to call it. There's lots of different names. I don't know what your favorite is. I assume most of you have touched data from BRFS at some point in your career. Is that correct? Okay. So what do you think is the biggest question I get about BRFSS as it relates to community assessments, localized data, that sort of thing? Anyone?
Can we get the data for our county?
Can we get the data for our county? And what's the answer?
No. Not over a certain amount of years, pooled data, maybe.
Possibly. So that's one of the methodologies there. So let me walk through a little bit, and I'll tackle that question in a second. So some background on the BRFS. Monitors modifiable risk factors associated with chronic and communicable diseases. Okay? So it's really one of our best sources to do that. All 50 states do it. DC participates, so it's nice because it's national, so we can do a lot of comparisons across the country. What it is a random dial telephone survey, so it's right now mainly landlines, and I'll go into the cell phone kind of thing in a little bit. It's adults only, for the most part. There is some other specialty modules that you can add on that look at kids and ask parents about their kids and that sort of thing. But for the most part, it's adults age 18 years and older who are non-institutionalized. And its sample is based on the state's population, not the population of smaller geographic areas. And that's the issue that we come up across with doing localized data. So the CDC BRFS staff have gone about trying to figure out ways they can do this a little bit better. So one of the new things that they're going to be introducing with the 2011 BRFSS is this new thing called raking methodology. So before, in Indiana, they take their sample, they say, okay, this is the sample for Indiana, it's reflective of your demographics. We'll weight each of those individuals to make up the total population of Indiana, so then you can describe what's going on in Indiana. The raking methodology will be doing that, but it's going to be taking more demographic characteristics into account. It's also now going to be able to infuse the data that we're collecting on cell phones, which is a huge thing, because which target population do you think we're missing the most with cell phones? The young adults, yeah. So right now we're really minimally collecting data on that, let's say 18 to 25 in particular, but maybe even the earlier, some of the adults that are the next generation up. What this will do now is be able to collect that data from the cell phones, connect it back to the landline data so you have even more rich data. So what we're expecting, though, which will be a good thing but a bad thing, is that I think we'll have more reliable estimates on some things, but things that impact those young adults more so, like smoking and that sort of thing, we're going to see some big jumps in some of those areas. So right now, as public health people, the community hasn't changed, but just how we're collecting our data has changed. So we're trying to figure out how to communicate that so when you see an uptick in tobacco use, that we can say, hey, it's not really an uptick, it's just the way that we've collected that data. And they're thinking through many ways about how to communicate that correctly and well and efficiently. So next on to primary data collection. So these are in other communities. They're kind of like, okay, we want to know what's going on in our community. We know there's secondary resources. We've looked through them. They're kind of cloudy. We don't really have great information. We need to go collect our own information. So what are they trying to go collect? Demographic, socioeconomic status data, psychological data, attitudes, awareness, intentions, motivations and behaviors, assets, and some of the public policies and organizational policies that are in their community. Some of their sampling strategies, and this is where it kind of gets iffy sometimes. As you'll see in some of my examples later on, a lot of these communities are teaming with outside organizations, which is probably the best way of doing this because, unfortunately, they just don't have the capacity. Maybe not even the local health department, they don't have the capacity to do an epidemiologic study or something of that nature. So a lot of times they'll revert to the bottom one, the non-probability sample, the sample of convenience, okay? Or they'll say, we just want to survey 100 people in our community. And that's just the best they can do. And that's probably going to be okay. Just knowing that they have to know the limitations of the data that they collect then. Fortunately, though, a lot of these groups are able to then team with a university, team with outside consultants, or that sort of thing, and maybe do some more probability samples, whether it's random, random selection, stratified, or clustered. They can use these types of methodologies in order to really understand what's going on in the community, have a really good feel and understanding of that point estimate that they get out of that confidence interval that they generate, that they feel like they're really describing their population well. So I'm just going to walk through a couple different ways that communities have done some of these studies. One of the first ones is observational study, and these are some more primary. This is probably even more qualitative understanding of what's going on. So they use the phenomenon around them to gather clues and generate conclusions about specific locales or experiences. So some of the pros are relatively inexpensive. It's just you being in your community, soaking up what's going on, and then trying to quantify that in some way, or at least write it down in an organized way. It's efficient and be conducted on foot. Some of the cons with that is it provides only an overview of the community. You can't really dive very deeper. It's more that maybe 1,000-foot view understanding of your community, and it requires closer observation to really identify previously unrecognized assets and issues. Okay, so this is more of your observation. Okay, where are we right now up here? And then maybe dive deeper after that. One of the interesting ways that groups have done some of this is called photo voice. Has anyone in here done photo voice? So it's taking a camera in your community or something that you want to explore and taking pictures. That picture says 1,000 words kind of concept. And going out and saying, okay, I want to take pictures of walking paths. I want to go take pictures of food options. I want to take pictures of green space or community gardens or that sort of thing and see where they are located, how well they're maintained, that sort of thing. Someone gave me a great example. They actually gave this photo voice opportunity to some students in a high school. They gave the cameras to those students, and they walked into their high school, into their lunchrooms, and that sort of thing, and took pictures of what the food options they had. And it's just a good way of getting that contextual, like, hey, this is my view of what I'm getting, so that when you come back and look at those photos, you can really describe what's going on in your community. So the viewpoint of those who live there records the community's strengths and concerns, that promotes critical dialogue and knowledge about community issues. So you throw a picture up there, you have a room like this, and you say, okay, what does this make you feel? Is this what your community is? And half the room might say yes, half the room might say no, the whole room might say yes. But then you can have some meaningful discussion about what that photo means in your community. Some of the cons or the analyses can be complex due to the volume of information. Requires photo release forms if you're taking pictures, especially of people or businesses, and can be expensive to develop. Now in the life of digital films, you probably not as much the last one. And then one of the biggest things that groups do are focus groups. A pure focus group is if you're running that focus group, that you need to be unbiased and not, you're just trying to get people to speak and open up and talk. You're not wanting to guide what they have to say. Somebody has given me an example, though, also of, okay, you're in a group, and someone in the group, in the focus group, starts to share something that's totally incorrect. You leading the focus group, they felt that you needed to correct that person. I think of a pure focus group, you need to stand back and let that play out and see how it goes. Now, maybe after the focus group, you can address that issue and say, hey, no, that's totally incorrect. We need to kind of correct that your viewpoint. Maybe they'll talk about your viewpoint a little bit more. But a pure focus group, you really want to see, because if you jumped into that person and they share something that's a little bit outlandish, you want to see what the other members of that focus group have to say. If they're all agreeing, that's going to be to cue to you that that's probably a system-wide issue that you're going to need to address. But if you nip it in the bud early on, you're not going to understand that. Or maybe the other members in that group all fire back and say, no, 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 there's no way that's correct. So I think you want to let that play out. So I wanted to touch base on some of our communities. I don't know out there if anyone is from Monroe County. So what have they done in Monroe County as far as community health assessment? So, hey, we want to know about our community because we want to start doing some meaningful stuff in our community, but we don't know. We need to collect some primary data for ourselves. So from 2008 to 2010, they started doing a health assessment atlas. It was a comprehensive assessment across multiple sectors of the community. They helped residents drive health-related policy and decision-making. So they started this in 2008, continued through 2010, and what they did do by this, and you can see that there's going to be overlap. So they've done two different major assessments. There's overlap, 2008 to 2010, 2009 to 2012. This showed and started to build capacity within their community to collect this kind of data and build the relationships and the communication lines. And then because of that, they were able to then get some extra funding to become an Achieve community, or the Action Communities for Health Innovation and Environmental Change, So they got extra funding by showing that they had that capacity. So what I tell communities is, hey, don't worry about having the big bucks maybe. Just start showing that you have capacity. Start building those linkages in your community, because then you can show that, hey, we can do this, and then you can get other resources down the line. So the first one first, the Health Assessment Atlas methodology. So quantitative data sources. So what they had been doing in Monroe County already is these scan reports that were more of a compilation of the social service needs assessment data going on in their community. They had been doing this back through, I think, at least the 90s, collecting this data. So they had some good trend data, some good already backbone of some of the some data sources they wanted to know about for their community. But then they went to the secondary data sources, a lot of the ones that I've already described before, to pull some of the secondary data that they could utilize for their community as well. And then for qualitative data sources, what they did is they got all the secondary data, these prior reports, they compiled it into nice public presentations, they went out to the community and did these town halls. And they said, hey, this is the data, this is how we're interpreting the data, is this correct? Okay, community member, is this how you view your community? And they, for the most part, they said, yeah, that's kind of how we're seeing it. So it helped them take, okay, secondary data sources, maybe older primary data sources, and started to kind of tweak it a little bit and make it more meaningful for their community. And then they got the funding for the Achieve. And then what they did with this is they implemented the change tool that I mentioned earlier on. And change tool is a really nice thing that walks you through, talks to you about how you set up a diverse group, how you go through many of the sectors in your community to really get overall buy-in and involvement from lots of diverse viewpoints and that sort of thing. And it kind of walks you through that. And then they're looking for community at large members, community institutions or organizations, healthcare, which was a huge thing for Monroe County, schools, and then work sites. And then they supplemented this with secondary data. So what were their findings of the Atlas? They had huge disparities in the southern portion of Bloomington and surrounding townships. So of course, you know, Bloomington area, the southern part is the non-university part, the northern part's the university part. And they started recognizing there's a lot of have-nots in the southern part of the community that they were looking at. And they needed to start addressing that. The Achieve reinforced a lot of those findings, but they got a little bit more specific about what they wanted to do. So I'm going to hop down a little bit. So opportunity for healthcare to actively engage in the prevention of chronic disease. So IU is a leader in healthcare and that sort of thing in our state. But what they started finding out is that a lot of the physicians and other healthcare professionals weren't asking a lot about, in their normal daily interactions with primary care setting with the patients, about nutrition status, about smoking, about their physical activity. So this was a cue to the physicians, like, hey, and they kind of, as they went through this, reflected on this themselves and said, hey, we need to start addressing this more. We need to start asking our patients more about this, and then latching them up with resources that are in the community. So it was kind of eye-opening for them. And then a lot of the play and food deserts were identified in the southern portion. So they're trying to explore ways about getting real grocery stores down there, not just convenient marts and that sort of thing. Great. So one of the big things in public health, and then we're working at the State Health Department, is how to really know our audience, how to understand and communicate and the strengths of our limitations of our data, and then be creative in sharing our data. So I'm just going to touch base on a couple of these different things. So we're really good about doing these bar charts and that kind of stuff, but we're trying to then tap that more into, okay, how many Hoosiers are impacted? So this is a thing that we did out in the eastern part of Indiana. This is for arthritis. I'll show you something from the eastern part of Indiana next. Showing the impact of arthritis on women in Indiana. So not just saying, hey, 34% of females in Indiana report arthritis in their life in 2009, but started getting some impact about, hey, that's over 800,000 women in Indiana. So that's a little bit more meaningful, right? Not just this number, this percentage, but hey, there's a number tied to that are people. But then taking to the next step in making it social math. So, who's been to Lucas Oil Stadium? Yeah, so about maybe almost half the group in here. Okay, so if I took those 800,000 women and I put them in the Lucas Oil Stadium, I would fill almost 13 Lucas Oil Stadiums with people that have arthritis. So that's the next step that's social math, of understanding the burden and impact. Now, with the way the Colts are playing, there's a lot of room, so we can fit lots of people in there, of course. But just that context gives people a lot more appreciation for what's going on in the community. So that's just one way. So this is the thing that we did out in eastern Indiana regarding overweight and obesity. We collected lots of years of BFSS data and kind of combined them together. Again, not the perfect methodology, but at least something that we could show how they're related to one another. Showing, here's Indiana, here's rates for overweight or obese, and then across these communities in eastern Indiana. Again, showing, okay, in Public Health District 6, 320,000 adults are considered overweight or obese. Okay, so that's a lot. That would fill up over 12 Randolph counties worth of adults. Okay, so if you're living in Randolph County, you're like, man, you filled up 12 of us with adults that are overweight and obese within our district. So again, a little bit more meaningful. Okay. One of the other things that we're trying to explore, and this is not a finalized version at all, so it won't be overly shared right now, but we're trying to figure out how to use infographics a little bit more. I don't know if anyone's used infographics or infographics. Some to depict data. I call it informative eye candy. So what it is you try to communicate data pictorially to communicate ideas and concepts, and then get people interested in that data, and then maybe take them to other sources if they want to learn more about it. Okay, so this is the incidence of cancer, how it relates to each other in Indiana. So again, this isn't a perfect thing yet, so because you're like, I can't quite understand all of it, but in relation to one another, breast cancer is impacting this many adults in Indiana, this percentage of adults in Indiana, compared to the other cancers. So it shows you overall what's the impact of each of the cancers related to each other. Does that kind of make sense? So it's a good snapshot view of, okay, breast cancer is huge, prostate cancer is huge, lung and bronchus cancer is huge. How do we get and start to address those issues? There's lots of examples out there. You can even go on Google. Information is beautiful, and it gives you lots of examples of different infographics. They're not all public health oriented, but it gives you ideas and ways that they've started to try to show some data that you might want to incorporate into what you're doing. Okay, great. Thank you very much.